Welcome to the one of the most important courses in the digital health systems track. In these in the EHR course, we learned how healthcare professionals create and document patient information. In this course, we now shift our perspective. We will explore what happened after information is created and how it moves through an entire health system. So when a patient visits a hospital, information rarely stays in one place. You may need to reach the lab, the pharmacy, the radiology department, the billing office, quality improvement teams, even hospital leadership. And in some cases, we report out to the Ministry of Health. Behind these information flows is an architecture that determines whether information arrives accurately, securely, and on time. This course is not about learning to configure servers or build networks. It's about developing the systems thinking needed to design and evaluate digital health ecosystems that help us improve care. Now, many organizations invest heavily in technology, but yet they continue to struggle with fragmented care, with duplicate testing, with deferred referrals, and unreliable reporting. These problems are rarely caused by technology or software alone. In fact, more often, they arise because systems are poorly connected or workflows were not adequately considered during interventions. Architecture provides the blueprint that ensures people, processes, and technologies, the tripartite, work together effectively and efficiently. Throughout this course, we will repeatedly return to one core principle, and that is that successful digital health transformation begins with understanding the health care problems, not the technology. Let me repeat. Successful digital health transformation in any healthcare organization begins with understanding the healthcare challenge, the healthcare problem that needs to be solved, and not selecting the technology. Now, we will use Mrs. Amina Bello as our use case. Mrs. Bello visits the Sunrise Regional Hospital somewhere in the northern Nigeria after discovering that she has a lump in her breast. She's examined in the outpatient clinic and referred for imaging and biopsy. Now, over the next week, the radiology report is completed but isn't available immediately to the surgeon. The pathology result is filled out but in a completely different system. The oncology clinic receives that incomplete referral in the first place. There were certain pieces of information that should have been in that referral form in the first place that wasn't there. And then Mrs. Bello returns for a follow-up, but her care team doesn't see the full picture because there are pockets of information that are missing. Now, nobody's made any error. Everybody's done, in quote, what they need to do. Yet, her diagnosis and treatment are delayed because critical pieces of information do not move as effectively and efficiently and with the speed between the departments that it needs to. Now, this story introduces a common challenge in many healthcare settings, particularly in low and medium income countries. Each department completes its own task, Yet, yet, the patient's care is delayed because information remains isolated. But as informaticists, we are trained to look beyond the individual uses and users of software applications. We ask how the entire system supports, or in this case, fails to support the movement of information across the patient's journey. Now, looking beyond the patient, the real problem is not simply that, or is not simply whether the information exists or not, right? The challenge is whether that information, even though it exists somewhere, the challenge is whether that information can move between the departments, move between the providers that need it to provide care, right? Move between the clinical care and the organizational decision making executives who need this. Now, when we talk of architecture in digital healthcare, what we're talking about is that which determines whether the information can travel safely, reliably, and efficiently across the system, across the health system. Now, this course shifts our perspective completely from the individual patient records to organizational information flow. In the course of this, for the end of this course, you will learn to see healthcare as a connected ecosystem in which every information handoff influences patient outcome, operational efficiency, research, and in fact, public health. Now, the question is, what is health systems architecture? Health systems architecture has been defined as the intentional design of how healthcare people, processes, information, applications, and technology work together to support patient care and organizational objectives. It provides a structure that enables health information to be captured, stored, exchanged, protected, and used effectively. Now, many learners initially associate architecture with buildings or computers. Think of architects that draw your building plans, right? But in digital health, architecture is the blueprint that connects healthcare operations with technology. Like a building blueprint, it provides structure even before construction begins. Without a well-designed architecture, without a well-designed plan, organizations often create isolated systems that cannot support coordinated care. We say that architecture is more than, and when I say architecture, I'm talking health systems architecture, is more than just technology, right? There are 5 domains that health systems architecture integrates into. And I've run by a few of them. So, first of all, people, right? When we talk of people, we're talking clinicians, we're talking administrators, we're talking the IT teams, you guys. And most importantly, the patients we're there to care for. That's one. Two, processes, right? The clinical workflows, the operational workflows, the SOPs that are written down so that everybody knows what they need to do, what the expected outcomes are, and how to do those. Number three, the information, the data generated during care. In fact, in healthcare, I'm gonna say that healthcare is one of the largest generators of data in ever, right? There's a copious amount of data generated in just one encounter, and we have to capture them securely and effectively. We have to store them securely and effectively, and we have to be able to utilize them securely and effectively. Number four, applications. So when we talk of applications, we're talking systems. We're talking the electronic health record systems. We're talking the lab information systems. We're talking the pharmacy systems. We're talking the radiology systems. And five, all of these sit on the infrastructure, right? The hardware. So the servers and the networks and the local area networks and the cloud services and even the security assets. So each domain depends on others. Technology alone cannot improve healthcare, right? An advanced electronic health record system, for instance, implemented without trained users or standardized workflow, will still provide poor quality data. But architecture succeeds only when these five domains are designed as an integrated whole and complement each other. Now you're looking at a diagram of a simple digital health architecture model. Now this diagram is foundational to this course, right? Throughout the next 3 weeks, or for the duration of this course, we will return to these five domains or five layers over and over again because they represent the essential component of every successful digital health system. Whether you're implementing an open MRS in a district hospital, whether you're designing a national health information exchange, or evaluating a hospital's digital maturity, these five layers provide a structured way to think and look at the problem or think about the problem. One of the most common mistakes in digital health projects is to begin with technology, right? So we ask, oh, what EHR should we buy? Should we buy Epic? Should we buy Cerner? Should we buy what's the technology? Should we move to the cloud or should we host this locally? But an informaticist approaches the problem differently. We begin by understanding the healthcare problem first, and then we systematically walk through each layer until we identify the technology that best supports our desired outcome, right? So we identify what the problem is, right? And then you almost like reverse engineer those steps to arrive at the most optimal solution to your problem. Now, let's briefly examine how these layers or domains align with each other in a typical digital health project. So the first layer is people, right? Every digital health project begins with the people who will use it or benefit from the system. Like I said, this includes patients, clinicians, nurses, health record officers, administrators, IT professionals, health policymakers. Each group has a different information need because they have different responsibilities. So if these users are not involved in the planning and design of this system, the system is unlikely to recognize and meet their needs, and most likely will face resistance from that particular um, group and not gain widespread adoption. So we must consider the individual needs of each of the stakeholder groups for this to be successful. Now, the second layer is processes. Now, before introducing technology, we must understand how care is actually delivered. We must understand what the workflow is, how are patients registered, how are lab requests ordered, how are medications dispensed, do nurses give chemo or do doctors do the chemo, how are referrals managed. Digital systems should improve and standardize these workflows. But if they are bad workflows in the first place, automation is not going to make them efficient. All you will be doing is automating inefficient workflows. Now, as we learned in the EHR course, a poorly designed workflow remains inefficient, regardless of how fast your processing speed is, regardless of how cutting edge your computers are. Put in garbage, take out garbage. The third layer is the information layer. Once the workflow is understood, we determine what information must be captured, who needs it, when it should be available, and how it should move across the organization. Now, high quality information is the foundation of clinical care. We've gone through that in our Foundations of Health Informatics class, in our data standards and interoperability class, right? So high quality information, very crucial, and in fact is the foundation for clinical care. Not just clinical care, for operational management, because the managers need to understand what's going on, look at dashboards that are presented to them, understand management data that is presented to them, and act on them. Poor information quality at this stage limits the value of every layer above it. If that information is inaccurate or if that information is incomplete, it's going to very adversely affect the workflow, right? It's going to make the workflow inefficient. And it's going to make the people who use that inefficient workflow, because the outcomes are not going to be optimal, right? They are going to miss their targets over and over again because the information is incorrect. So if that information is wrong, everything above that layer invariably will be inefficient. Now the fourth layer is the applications. Only after understanding people, processes, and information do we select the appropriate digital tools. So first of all, you must understand the needs of the people who will use this and for what it will be used. You must understand the workflow that this supports, and you must understand the information that is being collected and processed with this digital tool. Then and only then can you now ask, what is the best tool to do ABC? The goal is not to have many applications, right? It is to ensure that the right applications support the clinical work and exchange information effectively. Now, the fifth layer is the infrastructure layer. So finally, every application depends on a reliable infrastructure. And let me take a step back. So in the fourth layer of applications, right? When we talk of applications, they may include the EHR, like Open MRS, right, for patient records. But we may also decide to get an external application for lab information system, another application for pharmacy management system, a completely different one for radiology, or even the national reporting. We may get the DHIS too. The critical thing here, as we saw in our interoperability class, is that all these need to talk to each other, right? If all these systems are interoperable and can talk to each other, right? Regardless of how many they are. Again, like I said, the goal is not the essence of building this is not to have 1,000 different systems, right? The goal is to have the right applications to support what we need to do. So if one application is not able to accomplish everything we need to, then we should think about getting additional applications. So long as they're able to support our clinical work and, just as importantly, exchange information efficiently. Now, the fifth layer is infrastructure, right? Every application depends on reliable infrastructure. This includes networks, servers, internet connectivity. That's a big one, especially in low and medium income countries. Cloud services, databases, backup systems, cybersecurity measures, right? The infrastructure is often invisible to the end user. And that's the ideal situation, right? The end user, the nurse, the doctor shouldn't have to worry if the information they are generating is going to be backed up correctly at the end of the day. That's not their job, right? So the infrastructure should be invisible to the end user. But of course, we know that without it, the digital health systems cannot operate reliably or securely. Now, so considering the typical district hospital we've used that as an example that is implementing Open MRS, the people include, just mention them, right? The people, the processes, the information that people generate using those processes, the applications they use to generate that information, and finally, the infrastructure that keeps the whole system available and functioning. The important lesson here is that these 5 layers must be interdependent. A weakness or a strain in any one layer affects the performance of the entire digital health system. Now, looking at the table we have here, we've tried to break down architecture into 2 buckets, so to say. So the clinical architecture and the technical architecture. Now, the clinical architecture includes things like patient journey, right? Clinical workflow, documentation practices, care coordination, decision making, clinical decision making, right? And what clinical architecture essentially defines what healthcare needs the patients have. On the other hand, the technical architecture talks about the hardware, the software, networks, servers, databases, applications, and their integration, right? And it defines how technology supports those clinical needs. Now, an informaticist bridges those 2 perspectives. So clinicians understand patient care while the technical teams understand infrastructure. However, The informaticist sits at that confluence, sits at that intersection, right? And helps them translate between the two groups to ensure that technology serves the clinical objectives rather than dictating them. Thinking like an informaticist. Before proposing a technology solution, if you remember from the last slide, we said that you have to define the problem first before thinking of a solution that a technological solution that is suitable for that problem, right? So even before you start out, there are certain questions you as an informaticist will ask. What healthcare problem are we looking to solve? What information is needed, right? Who needs this information and why and how? When and where is it needed? And then finally, what architecture will make this possible? Now, for each of these questions, for each of these 5 questions, you have to understand what the problem is or understand what information is needed, right? You have to analyze what the healthcare problem is or what the information is or who needs the information, right? So there is also a series of steps you have to go through to understand, to analyze, to inform, to align, and then solve. The culmination of solving it will be answering each of those 5 questions for you. Now, these 5 questions will become a recurring theme and framework throughout this digital track because that is the essence of what you do, right? So I encourage you to begin with clinical and organizational needs before considering technology. And that's the right sequence. The reality in most low and medium income countries, fast hospitals and facilities there is that there is usually a hodgepodge of applications that are used for different purposes, right? And each tool works independently. Sometimes, most times, together they do not function as a digital health ecosystem. So you may have the open MRS for outpatient care. You may have the lab still using paper, for instance, right? The pharmacy is still documenting manually. Your external reporting to the ministry still uses Excel, for instance, right? And you still use SMX texts on your texts on your mobile phone for referrals. Now, many low and medium income country organizations still operate in this manner. They still use this hybrid environment. This is not a failure. It just reflects the resource constraints and the phase digital transformation. Just because we have a hodgepodge of systems and applications, so long as they are all able to talk to each other to a large extent, right? The informaticist's role is to identify opportunities that improve information flow um, within these realities. This scenario reflects the reality in many healthcare facilities in Nigeria today. But I should tell you that digital transformation is not often an all or nothing process. In fact, many hospitals gradually adopt digital technologies over time. And there's a lot of reasons for that. Many of them don't want to deal with the disruption in patient care that comes with it, right? And two, and a big part of it is the huge cost that comes from implementing a comprehensive electronic health record system or a digital health system. And so we end up with the hybrid health information environment. Now, at first glance, the hospital in this example appears to have embraced digital health, right? Just because it uses open MRS and computers are available in some departments. And electronic reports are submitted to the, even though in Excel, but they're electronic anyway, are submitted to the Ministry of Health. However, when we examine how information moves through the hospital, we discover that the individual systems largely operate as silos in isolation. So the challenge is not simply the absence of technology. We have open MRS, we have the Excel, we have um, um, uh, mobile referrals. So it's not the absence of technology, it is the absence of an integrated architecture. Now let's look at each of these components more closely. Now, the open MRS for outpatient care, for instance. So the outpatient department uses open MRS to register our patients and document clinical encounters. I would assume everybody listening to this now is comfortable doing that. We did it multiple times as a demo in open MRS. So this represents an important step towards digital healthcare, right? Because then you document patient demographics, the diagnosis, the medications, and you write your clinical notes, and they're all stored electronically, allowing clinicians to retrieve these patient records more easily than paper charts. However, OpenMRS captures only one part of the patient's journey, right? If other departments are not connected, the EHR becomes an isolated, just a repository rather than the central source of truth of clinical information. So, as an informaticist who is architecting this digital health system, I'm going to ask myself, can lab results automatically appear in the patient's record? Can the pharmacy see the clinician's prescription electronically? Can health administrators use data to understand overall service delivery? If the answer is no, then the value of the EHR is significantly reduced. So, although clinicians order lab tests electronically or perhaps document them in open MRS, but the lab itself continues to record specimens and results in paper logbook. This creates several problems, right? The lab staff must manually search for patient information. Their results may be delayed while paper reports are transported to clinics or maybe even get lost, right? Clinicians may not receive results before the patient's next visit, and so on. So the lab has the information, but is not easily accessible to those who need it. Now, let's talk of the manual pharmacy records. The pharmacist still relies on handwritten prescription logs and stock books. They do not have electronic integration. So pharmacists may not re-enter information already documented by clinicians. They have to manually write out everything from the scratch. And we know our fellow clinicians how great our handwritings are, creating opportunities for medication error, right? Drug inventory is difficult to monitor accurately. Hospital managers cannot reliably analyze medication utilization because it's on paper. You can't easily run a report on paper. So notice that the problem is not simply duplication of work, it's the inability to create one trusted source of truth, one version of the patient's medical history. Now, using Excel for ministry reporting, most rural organizations, most institutions in Nigeria, most hospitals, especially the government ones, do this. At the end of every month, staff manually review paper registries and electronic records, whatever they have, to prepare reports required by the Ministry of Health. So things like childbirth, things like vaccinations, things like um, stuff like that. Things like incidents of tuberculosis, those, especially in Nigeria, those are recorded. So this process often involves copying information from multiple sources and then reconciling the conflicting numbers, performing manual calculations, and if it's in spreadsheets, manually and doing data entry in spreadsheets and summarizing the data. So you see that manual reporting consumes a huge and valuable staff time and increases the likelihood of transcription errors. But more importantly, hospital leaders and public health officials may be making decisions based on data that is or that are incomplete and inconsistent. So a well-designed digital architecture would allow much of this reporting to be generated automatically from routine clinical documentation. Now the big picture. Is each department doing its job? Is each system functioning independently? Is each healthcare worker making every effort to provide good care? More importantly, is the health system as a whole functioning as an integrated digital ecosystem? Now, our perspective as an informaticist is not asking what new software should we purchase. No. What's the best technology for this? No, that's not the right question. Correct questions, the deeper questions should be, where does this information originate from and how do we capture it there? Where does it stop moving? Which departments cannot share information? Identify the pain points. Walk back from those pain points, from those problems, from those challenges, and then arrive at an optimal solution. Now we're going to use the Sunrise Medical Hospital as our case study, right? We're going to follow um, Mrs. Amina, right? And we're going to have you, as the analyst, join the hospital's digital transformation team. Here, your role, very clear, your role is to help design the digital ecosystem so that it improves continuity of care, right? So that that ecosystem is able to connect multiple health information systems and support reliable decision making and hopefully grow over time sustainably. So for the rest of this course, each week we will expand and refine the hospital's architecture and by implication, your role in building that. So you're not passive observers to this process, right? You will be integral members of the implementation team, making decisions that shape the hospital's digital future. The goal here is to encourage and to prod and to nudge that team towards um, continuous real life digital transformation, so that this where the systems evolve incrementally rather than looking to implemented at once. So for this segment, we have a few key takeaways. Remember that health systems architecture is not about enabling information flow, right? It's not, or it is about enabling information flow. I'm sorry. So technology is only one part of it, right? Remember, we have people, we have processes. So technology is only a piece of it, and shouldn't be the be all and all. Effective architecture integrates people, processes, information, applications, and infrastructure, right? And as informaticists, we think in systems and not necessarily in isolated technology. So, in conclusion, we're going to reinforce that architecture, health systems architecture, is fundamentally about creating reliable pathways for information, right? It's about enabling information flow. So, as learners in this course, I encourage you to begin to observe, and I had a conversation about this. I encourage you to begin to observe your own organizations differently, right? Um, um, take cognizance of the workflow, of their processes. Take cognizance of who is doing what and how, right? So instead of asking, what software do we use? We should ask, how does information move? Where does it stop? And why? So, how, where, and why? This is systems thinking mindset. And that's the foundation for the remainder of this course. Thank you.